aspect is screening. How are you going to screen those patients with different problems? As healthcare physicians, you should aware of what are the screening tools, and are you applying these screening tools appropriately or not. It's not just presenting complaint, history of presenting complaint. Screening the population is different, where you do not have any presenting complaint, you do not have any history of presenting complaint, but on the basis of age groups, on the basis of situations, on the basis of maybe family history, you plan for screening. So screening is different than taking a regular presenting complaints. All right. And by the way, screening can also be dealt as an opportunistic care. The patient has come to you for maybe a lady comes to you for a checkup for his sore throat, for his fever and things like that, and you find out that the lady is 55, and you may want to screen her up for the breast cancers. And same goes with the elderly patient. He's coming to you for a medication refill. He does not have any problem, and you would like to screen that elderly patient for maybe colorectal carcinoma, because all the adults geriatric age group should be screened for colorectal carcinoma and things like that. Maybe an adult coming to you for something, for some reason, age of 35 or 40, he is executive or doing office works, has a family history of diabetes, and he does not have a screen for diabetes and hypertension. Maybe you would like to see whether the patient does not have, is there any problem or not, because diabetes and hypertension in initial stages doesn't manifest with anything unless you screen them. So these screening tools should be applied effectively, relevantly. It should be for the benefit of the patient, for early diagnosis, to decrease the complications, to prevent the disease happening. So these screening tools have lot of advantages in terms of the cost, in terms of the quality of life, in terms of the prognosis, in terms of the complications. So if you want to decrease the disease burden, you need to screen those populations up, because our lifestyle is very unhealthy, and within these unhealthy lifestyles we tend to have these problems. And if we only, the way to decrease these disease burdens and outcomes and complications, you first need to screen the patients up. We will just touch upon 2-3 things on the screening tools. So if we talk about young females, cervical cancer screening. So if you see here, you do a pap smear. This group does not go into the gynae obs, right? No. Okay. So for young females, you do cervical screening checkups. Yes, for cervical screening checkups in the young population is from 17 or 18 till 25 or 30. You screen for cervical cancer. How? With the pap smear. You take a smear from the cervix, and then you put it in the slide, and then you have the interpretations. So any patients who think that she might want to do some cervical screening, cervical cancer screening, you do pap smear for them. So once the pap smear report is there, you need to have a basic understanding of what is this pap smear interpretation. Number one is normal. Normal is no nuclear abnormalities and place on routine recall. So you do cervical screening checkups every 5 years. You can go and look up these on the guidelines, NICE guidelines. We will base these screening criteria usually on the NICE guidelines. By the way, these screening criteria are very different from UK, US, America, and things like that. So we will do this on the basis of NICE guidelines for the standardization. So there is another thing called inadequate. So if the sample is inadequate, what does it mean? That there is insufficient material to diagnose to some certain thing. What you need to do is you repeat the smear as soon as possible. After 3 consecutive inadequate results, refer for colposcopy. So you do one pap smear, it says that it was inadequate. You do another pap smear, it says it was inadequate. You do third pap smear, it again says that it is not inadequate because there are no lot of secretions in it, and that's the reason only the pap smear is not sufficient to make the diagnosis as negative or positive. This is inadequate. So that means you need to maybe do a more invasive procedure, which is colposcopy. This is the second interpretation. The third result is borderline or mild dyskaryosis. This is 5 to 10% smears are borderline. Some nuclear abnormalities that are either conclusive or indicative of low grade CIN. So if you have this borderline thing, it's not going to give you a clear cut idea that the patient will have God forbid a cervical cancer. Then you check for HPV, human papillomavirus status. If the HPV is negative, then routine follow up 3 to 5 years. That means okay, it is borderline, but HPV, because HPV is human papillomavirus, is another risk factor that makes it more prone to develop cervical cancer, cervical cell carcinoma. In this, when there is HPV is negative, then you're sure that okay, the patient is safe. He is not having any risk for cervical cell carcinoma. You do it as a routine follow-up for 3 years or 5 years. But if you have moderate or severe dyskaryosis, moderate or severe dyskaryosis, that means reflecting to the probability of CIN2 or CIN3. This is carcinoma in situ neoplasms. So it's an advanced, a kind of an more pronounced and more demarcated stage where you need to do colposcopy. So these patients, they are not coming for any problem. So you just screen the young population, and on these, based on these populations and based on your results, you are going to do or manage or create your management plan. The tricky part is the borderline, because if it is normal, okay, 3 to 5 years. If it is abnormal, refer for colposcopy. But in between area, gray area, what is the gray area? The borderline. If the patient has borderline, then you see that you need to do HPV. If the HPV is positive, then you're going to refer the patient. If the HPV is negative, then you can say that okay, the patient is safe. And if the patient has inadequate, you need to repeat the test for 3 attempts. If all the 3 attempts are negative, then you go for colposcopy. Colposcopy, you refer on the basis of the results. If it is inadequate but 3 attempts are done, then you do colposcopy. You don't do because colposcopy is more invasive and more diagnostic with cervical carcinoma. But you cannot do for all the females. So this pap smear is a very basic test, and it is very doable and it is very cost effective. When you go into your gynae obstetricians, you will know how to do a pap smear. So we have discussed this is negative. If you referred the patient for colposcopy. Now if the colposcopy, what is the result of the colposcopy? One is negative. Okay, this is okay. You screen the patient for pap smear, but colposcopy was negative. You're safe. Then negative. The second thing is CIN1, 12 month with cytology plus minus colposcopy plus minus HPV triage if the borderline changes. So if the patient has CIN1, you are not going to treat until unless you have 12 months again follow up with the cytology. If the CIN1 has, if it is positive, it requires if the cytology at 6 months. So if you are treating the patient with CIN1 if we won't treat a patient who does not have HPV, who does not have any cytology problem, but if it is CIN1 with cytology, you need to repeat it at 6 months. CIN2 and 3, you require treatment. If a normal or borderline changes, HPV test confirms the cure. If HPV negative, return to 3 to 4 years follow up. If HPV positive, repeat the colposcopy. If moderate to severe, repeat the colposcopy. So if the colposcopy result is CIN1 or CIN2, you first need to see what is the problem and what is the extent. If the extent is moderate, you are going to repeat maybe, or you are going to test for HPV. If the HPV is also positive, you need to refer the patient for gynecological assessment and treatment. Usually CIN1, CIN2, it's a referral criteria. You should not deal it in a family physician clinic. You should take the help of the gynecological people. Yani 1, 2 and 3. Both. So there are different things, different findings in the cervical smear. If there is dyskaryotic glandular cells, you go for colposcopy. So we are discussing more cases in the cervical smear. If you are getting atrophy, you do a pap smear and there is atrophy, that means the patient is perimenopausal or postmenopausal. Because of that, they will having atrophic the results, and you do not require any action. If you see endometrial cells in the pap smear, it may be normal if IUCD is in situ. So you also need to ask to the patient whether there is intrauterine contraceptive devices she is using or not. Based on that, these endometrial cells may be normal, or if he is on the hormonal treatment or in the first half of the 28th cycle. Otherwise, discuss with the laboratory and refer if reported as abnormal. So discuss the endometrial cells. You need to take the understanding is that when you're doing your pap smear, you need to understand that what is the timing of that pap smear within the cycle. If the patient is on IUCD or not, if the patient is taking any hormonal treatment or not, what is the age, if the patient is perimenopausal or postmenopausal or not. Then there are some finding of which says inflammatory changes, which is because of the vaginal discharge or vaginal infections. You take the chlamydial and swabs and treat as necessary. Then trichomonas, candidiasis. So if it is suggestive of any infections of these category, you need to treat accordingly. So we have discussed about cervical cancer screening. In these, we discussed about pap smears, the findings of the pap smears, and when we should go and step up to colposcopy. And if we find normal colposcopy, 3 to 5 year follow up, normal. If we have abnormal findings in the colposcopy, CIN1, CIN2, CIN3, then you probably would like to revisit, or you probably would like to plan accordingly according to the scenario. So this was about cervical cancer. If you go, this is young females. We are targeting young females and screening for this problem. It's very common. Then we go on to the problems of the females or women's which are a little bit older or which has family history. So you need to screen for breast. How? So urgent referral for patient with breast diseases to be seen in less than 2 weeks is always required for lump. So when do you require an urgent referral? If the patient has lump, any age with discrete, hard and fixed with or without skin teething, any lump in the breast is not a referral criteria. But lump in the breast with these characteristics is the referring criteria. It should be if it is hard, if it is discrete, and if it is fixed with the skin. If you touch the lump, if it is mobile and it is not adherent to the subcutaneous tissue, it is not fixed, then it may be a normal lump in the breast. And if there is skin teething, any skin deformations are present or not. So this is how you're going to see the skin teething. This is the referral criteria for the for the lump. Number one. Number second scenario is if the patient has lump and is a positive history of breast cancer, family history is positive, then obviously you need to take the referral. Further lump or suspicious symptoms, the symptoms which you do not correlate with the lump, it is not going and coming back with the cycles maybe. So this is normal physiology. So if you think that there is any suspicion with this lump, you can refer the patient. Asymmetrical nodularity, if the patient has this lump with an asymmetrical nodules, it persists after the next period. So the lump usually comes and goes with the period and cycles. So if it is regressing, it's okay, no problem. But if it is persisting with irregular nodularities, you should think of something else rather than just a benign lump. If the patient is greater than 30 with discrete lump that persists after the next period or the presence after the menopause. So if the patient has age group which is a bit older, greater than 30, with some discrete lump and it persists. So anything persisting to the cycle is very, after the cycle, is very alarming. If the patient is menopausal and then she is developing a lump, obviously you need to think of these breast, you need to screen those patients and refer those patients up for further management. If you think of nipple discharge, every nipple discharge is not physiological, is not pathological, and it's not referral criteria. Nipple discharge with unilateral eczematous skin or nipple changes that does not respond to the topical treatment. So anything which is unilateral, has some eczematous problems, this is how you think of any suspicious discharge. Nipple distorted of recent onset and spontaneous unilateral bloody nipple discharge is the referring criteria for the patient who has lump in the breast or discharge on the breast. So these are some differentiating points. You always need to differentiate normal with abnormal, physiology with pathology, suspicious with non-suspicious. So every time you seeing the patient, you need to decide whether you want to refer or you want to keep or you want to treat or you want to do something else. So if you see physiological thing, as far as the discharge is concerned, it is bilateral, multiple ducts, on expressions only, green, milky, and stains only. If these are the characteristics present, it is normal. But when it is pathological means because of any disease or because of any God forbidden any cancer. If the discharge is unilateral, not bilateral, if there is single duct involvement, if it is just spontaneous, red, brown, and if it is profuse and watery, these are the things that you should think of the problem, that this is because of any pathological causes. So you would, when you are going to screen the patient for breast cancers, you will, every woman with greater than 50 years, you need to screen the patient, and this is not, there are two questions. One is what age group, the second is which test mortality. The first question, the answer for the first question is every woman with greater than 50 years of age you should screen her for breast cancer. Any patient who is coming to you for any reason, if you find that and you have the ability or you have the resources, you should offer this screening tool to that patient. Any woman with age of greater than 50. Which modality? Mammogram. Because mammogram is going to diagnose and is going to screen this patient up very, very effectively. But in which cases, and you need to screen it every 3 years, and it detects 85% of the cancers. When you will going to diagnose the patient, when you want to screen the patient before early 50 years, if the patient has obviously the family history, if there is any if she is at high risk, and the woman known to have a genetic mutation or MRI surveillance should also be offered for women 30 to 39 years because 10-year risk is greater than 8%. And the problem in the younger age group, if you find that the patient is younger, like 30, 35, and there is a high risk of there's a family history is positive, or she has genetic mutations that are there, then you would like to know that why this then mammography is not a very good option, because mammography is not going to give you very correct results. In those patients who are younger, because they have good parenchymal tissues, because of that the mammography results are not very specific. For younger patients, you do ultrasound. Ultrasound breast is going to give you more accurate results than mammogram. So in those patients, you want to screen the patient earlier than 50, maybe 40, 30. The modality is ultrasound rather than mammogram or MRI. Obviously, MRI is no doubt about the fact is a specific test. But these are the tests that you are going to do in those patients which you see here is high risk. Is this clear for this? These are the two things, and yes.
Can you go back to the picture of this cheese? Okay, and the first slide, the fourth slide, this slide.
Yeah.
I didn't see if the grade is CIN1, shall we give treatment or no? In which cases?
You give no treatment if there is CIN1 is present, but the cytology or colposcopy or HPV, they are in the borderline. They are not very suggestive of any dyskaryosis. So there is the CIN1 is present, but the severity is not much. If the cytology has more, because when the colposcopy is done, you also do cytology. You also need to see the extent. What is the extent of the cell's deformity? If the cell's deformity is not very much, or if there is HPV negative, then the CIN1 will not need any treatment. But if these things are very moderate dyskaryosis, or if there is HPV positive, then you probably would require treatment. But in any ways, CIN1, CIN2, CIN3, these are all referral criteria for you as a family physician to begin with. Your job is to diagnose or to screen the patient, and then with CIN1, CIN2 and CIN3, you need a gynecologist opinion on that, because he is the person who can decide whether he wants to treat it or he does not want to treat it based on the pros and cons of the individual patient. So as family physicians, you are not required to maybe remember the things, but you should be aware that even CIN1 may not require the treatment, and she does not require any chemotherapy or physiotherapy, things like that, or radiotherapy. This is for the counseling. If a patient comes to you and with the result of CIN1, then the patient will say that, okay, doctor, do I have cervical cancer, and is it really requires me to go for the resections and all? Then obviously you are going to say to the patient that it is not necessarily, because based on cytology results, based on HPV. But the decision maker would be the gynecologist, not you. Okay, all right.